Well, Happy New Year, ILC community. Thanks so much for spending your afternoon with us or your evening, depending on where you're at. My name is Matt Sikora. It's good to see you, and I know a lot of friendly faces here, but I know we got a lot of traffic from LBCA today. So thanks for joining us. Happy to connect with you all. So today we're going to review ILC data and some other relevant findings that were reported at the San Antonio Breast Cancer Symposium just last month. I'm going to be quiet for a few minutes while Donna and Carolyn, are two of our fearless leaders from Front Range ILC, take over and get us rolling.
Great. Thanks, Matt. Welcome, everybody. It's great to see some familiar faces and familiar names and some new ones. I'm Donna, one of the leaders of Front Range ILC Network. And I had the fantastic opportunity via LBCA to attend SABCS in person, along with Carolyn and Matt, as you can see there. And I know many of you, I recognize many names and I saw many of you there, but I also recognize that there's people on the call that don't necessarily do advocacy or maybe attend conferences. So what I wanted to do was to kind of show you what the conference was like. And then I'll give you kind of just a brief list of my takeaways before I hand it over to Carolyn. Okay, so go ahead, Matt. If you're new to this group, Front Range ILC is a group that was formed in early 2023, and so we are based in Colorado, mostly the Front Range, but actually serve the entire state. We support individuals diagnosed with ILC, and we have a very lofty mission to provide local patient support and networking opportunities for ILC patient advocacy and to provide education on ILC to patients and clinicians in the region. And Matt's lab is part of FRILC and hosts our website. Yeah, here's the slide. I don't know if you want to say anything about this, Matt, since it's your
Sure.
group.
So it's been a lot of fun to partner with Donna and Tracy Cushing. I don't know if Tracy's on, and Judy and Carolyn in forming and working with Front Range ILC. But my lab we're a breast cancer research lab. We also study gynecologic cancers based at the University of Colorado Anschutz Medical Campus and the School of Medicine in Aurora, Colorado. This is my rowdy bunch in the top right here. We have, I think, the distinction, the honor of being the only lab in the Mountain West that focuses on ILC biology to actually understand this disease at the molecular level. With Front Range ILC, we hold roughly biannual education and outreach events together to both educate this community about what we're doing in the lab, and then as much as possible to do things like this where we talk about what we do know about the disease and what we're learning as a field. And you can always learn more about what we're working on now at the lab website. But the bottom here are a couple of examples of some of the events we've done together with Front Range ILC.
Great. Okay, agenda. You just want to run through that quick here. We'll talk about research, right? What else is on the list there? Yeah. Carolyn and I will talk about the patient perspective. Matt has a fantastic summary of research focused on ILC. And then for those of you that are kind of curious about what's on the docket for this year, we've got a couple of things to watch for.
But these resources that are listed here are excellent. You're welcome to reach out to me and I can point you to a direction. And LBCA is very much the definitive source for a lot of this information. So please visit their For Patients section of the website.
Okay, so SABCS is the San Antonio Breast Cancer Symposium, the largest breast cancer conference in the world. These are some stats that they shared with us post-meeting. I added the sub-bullets there. I think it's really important to note that of all the registered attendees, and those are both in person and online, there were over 400 patient advocates that were involved. And the other thing that I wanted to make sure people were aware of, if you're interested in doing advocacy, um, there are many organizations that will kind of help train you. And a lot of those organizations also have opportunities to apply for travel grants to attend conferences like this. So I was super fortunate that my trip was funded in part by LBCA, and I know Carolyn was able to go through funding from Alamo. Um, the last bullet is also notable that the presence of lobular breast cancer at the symposium was significant. And I think you'll see that come out in the research summary that Matt does. Okay, next slide. So for those of you that have never been, the patient advocates are kind of everywhere, but it's really nice. They actually have a special lounge devoted to patient advocates. We snuck Matt in after some begging and pleading so we could have a meeting there, but they generally don't let anyone in except for patient advocates. It was sponsored by Lilly. You can see from the top photo, lots of places to sit, table rounds. It was a great place to meet other advocates, or as a general place to kind of decompress. They also served us real food. It wasn't just, crackers and cheese. And then they tried to do a group photo, and this is only a subset of the advocates. And actually, a lot of people are blocked by others, so you can't really see them all. But it was impressive, the number of patient advocates that were there. All right, next slide. Another thing that I wanted to share is the exhibit hall. If any of you have been to conferences, there's often an exhibit hall where companies will have space where they can talk about their products. So what you can see here are a lot of the pharmaceutical companies that were there to basically interface with clinicians and some researchers. On the lower left is a photograph of the patient advocacy pavilion. So LBCA, along with other groups, patient advocate groups, had a presence there, and they had us all kind of in a square, and so people could kind of walk around and see what resources there were for patients. And what was interesting is that there were, the people that came by the booth, it was everybody. It wasn't just patients, but there were clinicians and researchers that were interested in what was going on. So that's the exhibit hall. And then there were lots of different talks and sessions. Adjacent to the exhibit hall was a space for posters, but the speaking sessions were generally held in very large rooms. This was actually one of the smaller rooms, and these are photos of our lobular oral session, which was the first time that was done at SABCS. And for me, the thing that was so impressive was the number of people that were in this session. So it attracted a lot of people that were attending the meeting, not necessarily just those that were focused on lobular. And another thing that's really important to note is that I believe this year, they actually had patient advocates on every panel. And so after there would be you can kind of see the people that are sitting at the table there. After there would be talks, they would often have a discussion, and the patient advocate would be part of that. I went to a couple sessions where the patient advocates also gave presentations. So it was really great to see the patient voice integrated into the whole thread of the conference. Okay, and the other thing that I will share, many of you that were there were at the patient advocate breakfast with Dr. Muabi. And so we had a really great opportunity to just chat with him informally, and it was a really vibrant discussion. We had photos of the whole group, and then we also had those of us with metastatic disease were also decided we wanted a photo as well. So that was a really great opportunity. appreciate LBCA for putting that together. So that hopefully gives you a sense for kind of what the conference was like. There was a lot more that I could share, but I won't. Um, I attended a lot of different kinds of sessions, and I just kind of summarized the key takeaways. I have pages of notes, as I know many of you that attended did. Um, the thing that struck me is that there was a lot of basic research presented for understanding ILC and the histology. Matt's going to talk a little bit about that, but I thought that was really good and important, and I learned a lot. Um, there was a lot of discussion at SABCS about ctDNA, so liquid biopsies, and in general, but then also specifically about lobular, which I also thought was really great to see. And then the other thing that I kind of took away, and there was a lot of discussion about it, was the role of GLP-1 therapies in breast cancer and the impact that it can have, the increased efficacy and things like that. So those were things that kind of struck me. Um, the other session that I went to that I thought was really interesting was about CDK4/6 inhibitors, both in early and metastatic settings. There wasn't a lot specific about ILC, but there's a lot of discussion about the use of CDKs in different settings. And of course, I think that with time, we'll see that have some lobular specific data. So those are my takeaways. I know Carolyn also has some, so I'll pass it over to her.
Thanks, Donna. Since I'm new to patient advocacy, I've got a bit more of a crutch here in my slides with some more notes, just partially because I wanted people to be able to refer to the trials or the studies that are in caps that I've tried to reference, or what some of the information, where it came from. So I've got a few pages here, but one of my key observations in my first breast cancer symposium was this overarching eye towards personalized medicine, precision medicine, they call it sometimes, right? So some of this is different folks looking at different ways to create maybe a endocrine sensitive to endocrine therapy biomarker that is, some combination in a test that might help predict whether or not endocrine therapy is going to be great for you. And if you get a low score, then maybe chemo is a good idea. But there was a lot of talk in the Dana-Farber Dr. Otto Metzger talk about chemo and whether or not it's appropriate for ILC and whether or not we should write it off or not. And I think his point overall was that it's not clear still. There's a lot of space for just thinking about it in any particular issue. And then another note that I thought was interesting was that, hey, the typical risk stratification for deciding your treatment path is based on tumor size. And, somebody in the talks pointed out ILC, I think it was Metzger, that, ILC 5 centimeters is different than IDC 5 centimeters in tumor burden, because we're flat or some weird shape rather than some lumpy thing. So that's something to think about. And then I'm coming from tech, so I was interested in the artificial intelligence angle, the other AI, so to speak. And I think it's really going to be helpful in putting together all this data that we're creating. One of the talks at the end of the wrap up session for the week mentioned there were like 32,000 papers on breast cancer this year in PubMed, if you did a search on breast cancer. So, there's just a ton of data happening. And as different folks are looking at AI tools, and two that stood out were the country of Sweden with several of their research labs, but also Mayo Clinic is setting up some big data stuff. So, just pulling together all of the histology, the radiology, all those parts. So I thought that was interesting. And that's really going to help tailor treatment as well. Secondary benefit that was a surprise to me is that the Swedish team pointed out data on the variance in radiologist interpretations. And I think this is particularly true for ILC as well. And one of our other talks mentioned that the machine age can even be a factor. So, you just want to, as a patient, maybe think about these things And that's, I think, part of why sometimes we end up getting second opinions and whatnot. But go ahead, Matt. The other thing that stood out to me was more focusing on this, the area around the tumor and what's creating the environment that allows the cancer to grow, as opposed to just looking inside out from a single cell. And I thought a lot of that was interesting. The Brussels team said this could be a potentially effective outcome for ways to treat ILC. There's this whole thing about fibroblasts that I'm trying to learn better and understand better, but it can suppress the immune system and kind of protect the cancer and let it grow. And it also is going to be something Matt will mention later as one of the ways that one of the new scanning techniques is to leverage that to help find where the lobular might be. The dormancy triggers was an especially interesting session that surprised me. It sounded interesting. Why does stuff reactivate? And it's cool that they're looking into that. This was not ILC specific, but there was some C research that was presented that you may have seen in the news recently about how flu and COVID actually can create that inflammatory environment. And as well, there was another paper presented on stress, which was very scientific, really surprised me as well. And also just generally inflammation can support this this tumor environment. And those were particularly targeted at the lung. But that's, I think, ties back to what Donna said about GLP-1s, as they are anti-inflammatory in general. So maybe that's where some of that benefit from GLP-1s might be coming from. So a couple of trials on how to kill those dormant cells are happening as well, if you want to look into those. And then, the other thing that just jumped out, both talking to some of my doctors and one of the panels at the Alamo Breast Cancer Foundation that they had as part of their patient advocacy training, change is really slow in clinical practice. And while you have all of these, am I dropping out? Can you hear me? Are you okay, Matt? All right. Sorry, Karen. Hopefully we can get it in the recording. But the time it took decades, like 30 years, for the sentinel node testing practice and surgery to become standard. So, I know this really helped me in particular in my mastectomy, that they took fewer, axilla because of this technique. And it was just kind of a surprise to hear how slow things can go when you see so much change happening at the conference. And on the note of the future, just really future stuff, was this, if you've heard of CAR T, which, I read about in the news years ago, CAR T doesn't really work for breast cancer because of some of those protective and immunotherapy or immuno interactions, I guess Matt could tell you more. But they are starting to look at macrophages as a way to deliver more precise, different parts of the drugs that will help kill the cancer. And so they're following that CAR T thing, but the CAR-M stuff looked really interesting, and that's Dana-Farber if you want to go look into it. And then one thing I just wanted everyone to note, the FDA team talked about how they want to decentralize trials, because when you look at them, they often require you to be at, major cities teaching hospitals. And in order to do that, telehealth is a really big tool that they use in that decentralization, and it is at risk, I think, in the Medicare 2026 stuff. So, it might be worth contacting your officials on that. And then lastly, for the folks in the Denver area, when we went down to the GE booth in the exhibit hall, they told me that they're going to have the FES radiopharmaceutical in Denver starting this month. So if that's something you're interested in, you need to talk to your doctors and see, what it takes to get the training. They assured me the training was easy and can be done online or something, but that's the salesperson talking. So those were my notes, and now we'll turn it over to Matt.
But from my takes, I'll go more into the data on both lobular and some relevant non-lobular data that came up in San Antonio, which I've broken into news, and good news for the future. just to highlight again how big of a deal it was to have two lobular sessions at San Antonio, and LBCA gets a lot of credit for fighting this fight. It had been years before lobular could get any sort of attention at San Antonio, much less dedicated sessions. And I think this year we actually started moving away from just educational sessions, and we're getting more into new science for lobular. Last year was the first time that we had, or 2024 was the first dedicated poster session, and this year we had both an opening day session, which is this one, and the poster session. So it really is a big deal for the community and highlights how much more research and how much more attention we're getting in the clinical and research space. As Donna mentioned, there were 121 abstracts that came up if you search for the word lobular, which is fabulous. About half of them were actually data on lobular, which is amazing. And the other half really just noted that they had a few lobular patients. That second half, though, is actually a really big deal because it also marks a change in just acknowledging that what histology the patients on different retrospective and prospective studies have. So while many of them only had 2-3 lobular patients, the fact that they're writing it down means now we can start thinking about asking questions after the fact, which we have not been able to do for a very long time. So it sounds like a small thing, but it really is a big victory for research in this space. As far as news, I also wanted to highlight this presentation from TAILOR-RX, which is a big study on the recurrence score, Oncotype DX. This was not in the lobular session. This was actually in one of the main rapid fire sessions. Big room full of people. The TAILOR-RX study was designed for molecularly low risk ER-positive breast cancer. So this was Oncotype scores 25 or below. And the trial was trying to decide whether or not that intermediate group does or does not benefit from chemo. And it's been studied now for many, many years. Something that was actually said, this was the quote from Dr. Salgado, was pointing out that at every single endpoint in the study, when they looked at lobular, the lobulars do worse at 15 years follow-up. And I don't say this as doom and gloom because it was not a huge difference in these images here, the yellow dashed line are lobular. And it's a few percentage points difference in terms of recurrence. And we've known this for a long time that lobular recurrences do get worse after this 5-year window. The big thing here, though, was that this was said in a room full of people that aren't otherwise thinking about lobular. And it's a huge deal for us as a community to combat the presumption that lobulars are low risk and unremarkable. So not new data per se, but it's a big deal, again, for the community to start thinking more about lobular and not just casting it aside as these are low risk, we don't need to study this. So it was encouraging. Some other news, this may sound ridiculous as much as we talk about identifying ILC, but we as a field are still arguing a bit over what we're actually calling ILC in terms of pathology. One of the opening sessions from our French colleagues pointed out that at the histological level, we do focus on the classic type of ILC, which is the single file infiltrate, this one at top right here. But two other common histological subtypes are also called solid, which is this lower left, and alveolar, which is the lower right. The cells still look like lobular cells, but obviously neither of these are that classic single file pattern, but they are still lobular cancer. They still have that classic loss of EK adherent. There's also other histologies that are sublobular classes called tubulolobular and trabecular. And then we're not even talking about pleomorphic ILC, which has at least 4 of its own subtypes. So we're not sure yet whether we need to classify these all differently in retrospective studies or whether we need to think about them in prospective studies, but it's something we're still arguing about as a field. We're also still wondering whether that classic EK adherent loss helps or hurts in actually helping us define what ILC is. A lot of trials, including those that are getting kicked around here in Colorado, are thinking about using ECAD loss as a molecular inclusion criteria to say it is lobular if it's lost EK adherent. The Europeans argued that this doesn't necessarily help, in part because they have identified a number of ILCs that have aberrant but not negative EK adherent staining, and we don't know what to do with that yet necessarily from a research perspective. Interestingly, that TAILOR-RX study that I just showed you did not use EK adherent, but still had fairly good concordance between pathologists calling lobular, but they did also use a machine learning artificial intelligence classifier to help them call ILC. So that was encouraging to see that kind of AI tool could actually help define lobular and hopefully reduce variability. And that's all to say just about pathological types. There's also molecular types. We've known for the last decade or so that there are probably at least 2 or 3 ILC subtypes at the gene expression level that we're still arguing about as a field over whether those are relevant and how to study them. A really nice study from the group at Pitt actually looked at tumor mutational signatures. They looked at individual mutations across tumors and found what it looks like 5 different subtypes, which is kind of these broad clusters here I'm pointing at on the bottom. And these have different types of mutations and patterns of genes that are mutated in the tumors. And these are actually differentially associated with outcome, with this one orange group being the worst in terms of recurrence. And we don't know how these connect to transcriptional subtypes, how they connect to pathological subtypes. So the next thing we'll be doing as a field is trying to understand whether these inform each other, where these actually represent different types of lobular cancer, and what we can do about that. As an aside, I'll mention that my lab here at Colorado is particularly interested in this orange subgroup and this high TMB, or tumor mutational burden. We have a paper that should just be coming out this week that we're hoping is a way to start thinking about targeting these tumors with high TMB. So ask me again in a couple of days and we can talk more about that. I put this one up as kind of ILC news because there was a little bit of data, but while we're getting traction overall for ILC, it is mostly focusing on ER positive ILC. There was very limited data on HER2 positive or triple negative ILC. There was one nice piece of data that did include lobular from the ALTO trial. This was a study, a retrospective analysis of one of the HER2 positive trials that went back to ask about the relative benefit of endocrine therapy with aromatase inhibitors versus tamoxifen as a SERM plus or minus ovarian function suppression in primary ER positive, HER2 positive breast cancer. The big conclusion from this retrospective study of ALTO showed that aromatase inhibitors are indeed superior to SERM with or without ovarian suppression. And even though there were not very many ILC on there, it was also true for ILC. Only 92 overall with only 20 events, but it's consistent with what we've learned about ILC overall that does argue that there is a stronger benefit for aromatase inhibitors versus tamoxifen in ILC. But hopefully this is the start of other HER2 positive trials going back and pulling out lobular data too. So this was at least a step in the right direction. Okay, this one I put a few pieces of news that are not ILC specific, but are relevant to our community just the same. The first is that there are at least 2 new oral SERDs or potential fulvestrant alternatives that are headed toward approval, not approved yet, but are on their way. We do already have in the last couple of years elacestrant and imlunestrant that are 2 oral SERDs that have gotten FDA approval. There was data, some of it recently published, some of it presented at SABCS, from the SERENA-6 trial, which looked at switching to camizestrant upon detection of ESR1 mutations or estrogen receptor mutations in circulating tumor DNA. They showed a benefit for switching to camizestrant. So this drug is probably on its way to approval and will be an option for many patients with ER-positive ILC. There was also exciting data presented from the LID-ERA trial, which supported that the oral SERD giredestrant is an option in the adjuvant setting, so upfront, potentially instead of current standard of care aromatase inhibitors or tamoxifen. And there's a whole bunch of other adjuvant trials using oral SERDs that are underway, meaning moving up the oral SERDs to the frontline setting immediately after surgery of primary breast cancer. In particular with giredestrant, this is exciting, but there are still some big questions about where the timing is for these drugs and when you still would use CDK4/6 inhibitors. The giredestrant trial did not allow the use of CDK4/6 inhibitors, so we're not actually sure if this single agent beats aromatase inhibitors plus palbociclib and friends. So there was a lot of discussion about whether there would be a switching strategy once giredestrant gets approved. I'll also bring up that there was no ILC data at all in any of these trials on the oral SERDs. We do have some lab data that raises some yellow red flags about some of these new drugs for ILC and whether they might behave more like tamoxifen does. We have a lot of work to do in that space, but hopefully we'll start getting ILC data from these trials to start answering that. Another exciting piece of data from a few trials that's relevant to this community is that some of these oral SERD combinations with targeted inhibitors like PI3K inhibitors, mTOR inhibitors may blunt some of the rapid resistance that we see in the second line setting. So in second line endocrine therapy, after the first recurrence or an advanced disease, rapid recurrence within the first few months can occur in up to 40% of patients on trials. And this has been known for a long time, and we haven't really known what to do about it. But there was data from the Avera trial and a few others that suggested that these combinations with everolimus and PI3K inhibitors may blunt or even overcome some of that rapid resistance. Again, no ILC data, but interesting just the same. This is one example from Avera. And this rapid resistance I'm talking about can be seen in the standard of care endocrine therapy arm here, where in this progression-free survival chart, even before 3 months, there's this rapid drop where up to 30% of patients in this group did experience recurrence very quickly despite having that standard of care endocrine therapy. With the switch from standard of care aromatase inhibitor to giredestrant, though, you see that there's a much lesser occurrence of that rapid recurrence. And that was in this trial seen in both ESR1 mutations and the overall trial. So I do think this is really encouraging that maybe using the better anti-estrogen that is more efficacious than AI or fulvestrant and better at hitting estrogen receptor can be a better combination with these combined therapies and get us over some of that anti-estrogen resistance hump. Obviously, there's a long way to go here, but I think it is encouraging because we've seen this rapid drop in a lot of trials for a very long time. The other general good news that I think there was actually a lot of excitement about was the last plenary session with the Wisdom trial. This was a kind of precision optimized breast cancer screening study that was led out of UCSF. And I think it is really going to redefine how breast cancer screening is done. It stratifies individuals into their relative risk based on family history, genetics, and other factors, and actually recommends then less frequent or more frequent mammograms, or for the most high-risk patients, right to MRIs. And it really did a phenomenal job in better detecting cancers before they became aggressive. No ILC data, but they have a ton of data, and I have no doubt that eventually we'll see what ILC looks like in this trial. But I asked my wife to sign up for it as soon as I got home, so I was really excited about this. Okay, there was some direct good news for ILC presented at San Antonio. With 2 presentations at SABCS, there are now 3 trials that support that CDK4/6 inhibitors may actually have a greater benefit for ILC than other ER-positive breast cancers. So the Penelope B trial was published earlier in 2025, and this was interesting because this was a trial for high-risk primary disease, and it was negative overall for a benefit of palbociclib, but this paper showed that there was actually a benefit for ILC specifically, which is probably one of the first times that we've seen a clinical trial report that there was a benefit specifically for ILC, which is exciting. At San Antonio, there were 2 additional trials that reported similar data. The PALACE trial also used palbociclib in primary disease. The trial was negative overall. And then MONALEESA-3 was ribociclib in the advanced metastatic setting and was positive overall. But both of these also saw a benefit in the ILC patients specifically. This is a snapshot from the PALACE poster with different forms of recurrence-free survival in these plots up here. And you can see that in the blue versus red, there's no change with adding palbociclib in no special type or ductal cancer patients. But in LABER, there was an improvement in all of these recurrence-free survival measures when adding palbociclib. So that's really exciting, consistent with Penelope B. And again, even though MONALEESA-3 was a positive trial overall for all patients, there was still clearly a strong benefit with adding ribociclib to fulvestrant in the advanced setting. That's the blue line in both of these graphs here. So these are both retrospective, or these are all retrospective analyses and have relatively small n's. This one in MONALEESA only had 110 patients. But CDK4/6 inhibitors are essentially standard of care and are going to be considered for any patient with ER-positive disease at this point. So it's very encouraging that there is a stronger benefit for LABER. That said, I don't want to minimize something that was talked about over and over and over again at San Antonio, which is the side effect profile for these drugs, which is not pleasant. So clearly, they're not the answer to everything, and we have a long way to go. But this was a really cool positive signal to see for ILC. Another piece of good news was on radiation therapy. So my group had published a review paper in 2025 about some data that we'd observed, and we looked at the literature to look at radiation response for patients with ILC. And the data we could cobble together said that, yes, it does look like patients with ILC do get greater benefit from radiation therapy than other patients. For this poster, a group at UCSF led by Rita Mukhtar, who is also chairing the ILC symposium that we'll mention later in next year, or this year. It's 2026 now, this year. She did an analysis from the National Cancer Database, specifically looking at patients that received post-mastectomy radiation therapy. So this is a specific set of patients that got mastectomies. She looked at overall survival in patients with IDC versus ILC that did or didn't get radiation. You can see that within the 5-year window of the study they had, that there was essentially an overlap with the ILC dipping below at that 5-year mark like we expect. But when you add radiation, there's a bigger benefit or a greater decrease in recurrence in the lobular patient group. And you can see this overall with the relative hazard ratio or reduction in recurrence from radiation. So again, because radiation is effectively standard of care, but arguably underutilized, especially for ER-positive, quote-unquote, low-risk disease, this is a really nice signal that radiation is indeed a great option for many patients with lobular breast cancer. Okay, and then I have a couple slides on good news for the future of ILC. I think my favorite takeaway for the future of ILC research was from the I-SPY trials. So I-SPY has been a long-running kind of rapid response trial design that has been run out of UCSF for many years, where they do small, nimble trials across many different breast cancer patients to quickly test therapies and decide which ones need to move on to phase 2 and phase 3 studies. But the problem with the general I-SPY protocol is that it is focused on relatively high-risk breast cancers. It is focused on those that are called MammaPrint high, which is another risk signature. So very few patients with ILC would qualify for I-SPY, which is very frustrating. But in the last year or two, they opened this new arm of I-SPY called EOP, or the Endocrine Optimization Protocol. And this series of studies is designed specifically for the quote-unquote low-risk ER-positive breast cancers that have low MammaPrint scores, which captures almost all lobular tumors. So with this, there is now a chunk of I-SPY that will capture lobular, and we can actually see lobular patients go on these trials. So there were 2 EOP trials that were presented from I-SPY at San Antonio. The first was with an ER-targeted therapy called vegdebestrant. That's the worst name I've come across for one of these drugs. It's an ER PROTAC, or it degrades the estrogen receptor. They had a total 121 patients enrolled, and 38% of these were ILC, which is phenomenal. They didn't present any ILC-specific data, but undoubtedly it'll be coming soon. But I don't think aside from the latest ILC design trials, there are no trials that have that many ILCs. Another study that was presented was comparisons of different SERM and SERD strategies that had 41% ILC, including 34% pure lobular. They didn't report the responses to individual therapies yet. That'll be coming. But one thing that was really cool out of this was that they're also using MRI as a potential measure of treatment response during the neoadjuvant setting, which may prove really powerful for lobular since it is otherwise hard to measure, especially in that pre-surgical setting. So really cool. And the fact that I-SPY is now essentially equipped to accept lobular is really exciting. And then for those of us in the FRILC community, CU Anschutz is an I-SPY site. So patients in the Denver area will have access to I-SPY trials. A few more pieces that are exciting for the future were how much effort there is now to analyze tumor mutations and circulating tumor DNA, or ctDNA, in ILC. The lobular poster session had 3 or 4 different presentations on ctDNA and tumor mutations from Pitt and Dana-Farber, looking at primary and metastatic disease and using at least 3 of the different commercial tests that are out there. All of them were strongly supportive of the idea that there are different genetic types of ILC with different vulnerabilities. Early days in the research, but all of these also represented truly huge cohorts with outstanding opportunities for research. I think the Pitt study using Signatera was 1,400 ILC patients, which is 10 times larger than the TCGA data set that we have. So tons of opportunities moving forward. Carolyn pointed this slide out to me, was in the day 1 session on lobular, and this is ongoing prospective initiatives looking at liquid biopsy or circulating tumor DNA in lobular, and it's got 6 active studies that are currently enrolling ILC patients. We're not quite in the using ctDNA to act phase yet, but we are getting into the how can we use ctDNA to track ILC and help us in future trials inform therapy response and potentially changing therapy based on changes in ctDNA. So because ILC does resist many other imaging and tracking modalities, I personally am also really excited about ctDNA and using this in our own studies moving forward. Finally, there wasn't any particularly exciting imaging data that was presented, but there were a whole bunch of groups that are going back to look at other imaging options for ILC and try to understand the relative utility of a lot of these different imaging options. So the biggest one was using different PET modalities. The most common one, and to hopefully answer Roxana's question from earlier, the most common modality for PET is this FDG or fluorodeoxyglucose tracer versus one of the more new options, which is fluoroestradiol or FES, and trying to understand how these two tracers are the thing that is injected to actually track the tumor and how these work for ILC. There is a general concern that ILC tumors are less glucose avid, meaning they suck up less sugar in general, and because FDG is sugar, a lot of times these tumors don't suck up as much sugar and may not light up the same way using the FDG tracer. On the other hand, since lobular tumors are more often ER positive, they do suck up the estrogen, the labeled estradiol. So groups are going back to figure out, when do patients show with FDG positive lesions? When do they show with FES positive lesions? When do and don't they overlap? And are there actually differences in biology, patient outcomes, and treatment options based on when the lesions are FDG versus FDS positive? There are a ton of other new tracers in development. There was one set of case studies, I think out of Memorial in New York, that was looking at this tracer FAPI, which is a microenvironment tracer, which Carolyn was alluding to earlier in the tumor microenvironment. For the life of me, I can't remember what this stands for, but it's a tracer to look for reactive fibroblasts in the microenvironment of breast tumors. And because lobular cancers are so much more closely entwined with the microenvironment, there's some hope that they may make this light up more than other breast cancers. So we'll see how this one becomes an option. There was also a discussion in general in a lot of sections about moving away from this being a one or the other question, or just using multiple tracers to better profile disease. And hopefully in Denver, with FBS becoming available this month, we'll be able to start answering that question here. And I know a lot of groups worldwide are starting to answer that. So I can't tell you which one is better yet, but there are options that should be considered for ILC, especially since the NCCN guidelines now do formally recognize that FES should be considered for ILC. Okay, that's the end of my data summary. Donna or Carolyn, do you want to take it away for the what to watch for?
Sure, I can tag team with Donna if you like. I know, Donna, you went to the International ILC Symposium a year ago, but it'll be 2 years come September, when it was in Brussels, was that it? And so you're on mute, though, if you want to.
Yes, just outside Brussels.
Yeah. So this happens every 2 years, I guess, and the next one is San Francisco. So there's I'm sure an opportunity for patient advocates there. I assumed that based on last time, right? Probably a lot smaller than SABCS, right?
I'll just say that this was actually one of the most interesting conferences I've been to. Correct me if I'm wrong, Matt, there were about 180 participants. Roughly a third were researchers, a third were clinicians, and a third were patient advocates. And it was a really integrated conference. So there was a lot of discussion across those three groups, and it was very interesting. It's in San Francisco, and so if any of you are able to go, I would highly recommend it.
And then also for SABCS, if it interests you, there are many organizations, like Donna said, that offer scholarship stipends. ABCF gave me a stipend. Alamo Breast Cancer Foundation, actually, I had no idea, but I learned they were sort of the beginning of patient advocacy. So they have some women that, back in the 90s were like, hey, we want to come to the conference. And I got to sit on the floor in the back of the room. And now, patient advocates are on every panel. So it's amazing what they've really helped drive. But yeah, you can apply for that one as well online. They've got a pretty formal program. So that's around all those things. And then for Front Range ILC, we are looking for a social and research fundraiser. We've got Saturday, April 11th afternoon pegged, and the proceeds will raise money for some lab things at the Sikora lab, since they're our backyard research team. Lob is a perfect place to do this. It is an indoor bocce style game, so they'll facilitate a little mini tournament. It's anyone can play. It's like bocce. If you haven't played it, you're rolling a ball, and it's kind of like mini golf. So yeah, appreciate the pun. So put that on your calendars, please, if you're in the area.
Yeah. And I will say too, for anybody that's on the call, if you're interested in training to be an advocate, please reach out. Happy to give you some resources. Or if you're an advocate and you're interested in going to conferences, I can also share a list of organizations that provides travel support. So.
Okay. Well, thanks everyone. Hopefully that was useful, helpful, interesting. We can go to open Q&A. There was a new one. There was one in the chat on metastatic disease and a new one in the Q&A. We can just start firing away here. I'll stop sharing for now.
Okay. Well, let's maybe go with Roxana's question. Is it worth getting FES scan versus a PET scan? Excellent question. I guess the first thing to say is like it depends on if you're hormone positive or not, because you need to be ER positive. There's indications that FES can identify lobular lesions better than PET.
Also, to be clear too,
I don't know.
FES is a type of PET, also just to avoid confusion.
Yeah. Thank you. FDG PET is the one that if you've gotten a PET, you've probably gotten an FDG PET. I don't know, Jade, I'm kind of looking at you to see if you want to weigh in on this.
Yeah, so FES probably has its best utility in lobular at initial staging prior to treatment to see where it is in the body, because once you start treating it, if an ESR1 mutation or something else causes your cancer to mutate into something that is no longer estrogen receptor positive or it's estrogen resistant, your cancer won't show up. So it is, I think in the later, it is an adjunct. It should be used in combination with other things to understand if there are places in your body that the FDG isn't as good as seeing, such as your bones and your brain. FES is better at those. It has a hard time in the liver, which is why the MRI is often paired with that if you have liver problems. But yeah, its primary, like its best use, I would say, is probably in the early, like when you're first diagnosed, before you start a new treatment, or if there's a question about you're switching to another endocrine treatment and you want to find out if cancer that you know is there is still estrogen receptor, like, you could still do endocrine therapy. Does that answer the question?
That was a great answer.
Thanks, Jade.
Great.
Yeah.
I think you talked to your doctor, and as from an insurance perspective, it hasn't been an issue for anyone I've heard from. I mean, it's just like a PET scan. So
yeah. I will say one other thing, which is that Gary Ulliner, no, it was Hannah Linden. A couple of years ago, I saw her and she said, should everybody get an FES? I don't know. But she did say something to the effect of, everybody deserves to see if they're FDG or FES avid. So there's so much interpatient variability. Like I may only show up on MRI, you may only show up on FES, somebody else is only FDG. So it is actually pretty important to not assume that this is going to be, that the the studies and the efficacy is going to be the same for you as for everybody else. There's just so much variation. So I do think it's worthwhile to pursue different types of imaging to see if one is the best one for you.
Hard agree. Jade, we should just have you as our radiologist proxy from now on. So a couple colleagues I was talking to at San Antonio were actually talking about, can we design trials to test just giving patients both FES and FDG simultaneously, just cover the whole thing. That doesn't quite.
I have a whole thing. I'm happy to talk to you about it at some point about cycling through them.
Yeah. So hard agree. I think that's going to be the way forward for all this. Before we get back to questions in the Q&A, there were a couple that in the chat that that Judy pointed out that I wanted to get to. Nicole had a comment about, considering ILC as an actual factor in diagnosis and management, and I could go off on that for a while, but in short, that's our goal. Right now, getting a differential diagnosis of ILC doesn't inform many clinicians, and we need to change that. And the goal is to make it so this is a routine part of care, that every patient knows whether they've got no special type, got lobular, got other special types, and how that directly impacts care. So I don't think we're there yet, unfortunately, but that's the goal, is to get there. And that's why we have so many trials, looking at this, and things like the CDK4/6 inhibitor data, like clearly, if a patient with ductal versus lobular, there's a huge conversation about palbociclib already. So we're getting there. We're getting there. And then the other one that I think Donna and Jade and Carolyn should take was from Layla about as a rightfully selfishly motivated metastatic ILC patient, what are the top things I should advocate for to help with ILC treatment and metastasis? Since we talked so much about that.
So you're saying advocate as like for a research advocate, you're advocating for development of those things, or advocate for yourself, like within your own care?
Layla, do you want to clarify? I'm reading your question as self advocate, but
yeah, I interpreted it as self as well. But
I saw a couple of short sleeve jean jackets, but I have to hear other jackets. I'm like, I gotta get one for the spring.
Oh.
Well, why don't we just say them both?
Yeah.
Okay. Yeah. Okay. So selfishly motivated. I mean, the bone only, you really should be very, very highly considered to have some sort of Zometa or Dasonimab or one of the other bone modifying agents that can help. There is actually there are some newer drugs that I can't remember the name of right now that are also looking very promising for bone. There's one that actually had like a complete response for lytic, which is not as common with ILC. We tend to have sclerotic bone lesions, but it was pretty amazing. That was the Zetamet.
Zetamet B3.
Amazing response. That looks very promising. But there's another one, and I'm just not remembering what it is.
Kirsten, do you mind? Kirsten, do you mind typing that in the?
Yep, I'll type it. I can send you.
Yeah, that's still in
interested.
Trials.
Sorry, I can send whoever's interested the poster on it, which would be even better.
I'd like to see it
but
too.
I have to say it's an intratumoral injection. Very interesting. But when I went and chased it myself, they were doing bone grafts. So it's not the company that's producing the intratumoral injection. They're not speaking about it yet on their site. So I thought I'd contact the scientists directly, but I'll send the poster in. I've got the poster somewhere, so I'll send it in.
Yeah,
thank you.
I'll mention too that with that lytic versus blastic question, that my lab actually has new models in lab that we actually see that ILC cells do that to bones in our animal models, and we're gearing up to start doing preclinical studies to see how these different therapies affect lytic versus blastic behavior and how that impacts bone health and hopefully recurrence. So
that's wonderful.
Lasofoxafen is a really promising trial. Lasofoxafen.
Maybe that's the one.
It was originally it was a bone drug, and later on it was repurposed because they found it had anti-cancer properties, and it's a kind of SERM-SERD juxtaposition. So it's got an interesting mechanism too. And Elaine 3 is just coming out. They're going to combine it with abemaciclib. At the moment, the only other way of getting it, and you might be able to get it by contacting Donald McDonnell through Compassionate Access.
We've
Yeah.
we've
And I
published some
think that,
training data for ILC and lasofoxifene, so I wouldn't go chasing that one just quite yet, personally.
yeah, and I think, Kirsten, that's also if you have the ESR1 mutation,
Yeah.
correct? Yeah.
Yeah.
I'll going back to Leila's question, I think in addition to what Jade said about a bone strengthener, um, I'm bone only over 6 years out, and one of the things that I've kind of learned is that when I have progression, it manifests in kind of a weird way, and it generally for me doesn't show up on imaging, CT or PET, and so I advocate for MRIs for particular areas, and MRIs actually will show the problem areas. So I guess I would just say if you have, any kind of change, pain, tingling, whatever, really try to get some imaging that's going to show what's going on. And lobular, is tricky on imaging, as Jade pointed out. So that's, I would say, the Zometa, and really advocate for MRIs or something else.
And I
Carolyn, do you have any
MRIs tend
thoughts?
to be the gold standard for bone.
Yeah.
For
Sure.
being able to see, especially sclerotic, because it can see inside the marrow and you can see the type of lesion it is, while CT just looks at the actual shape of it, like you can see it, but you cannot tell if it's sort of like going all the way through. Anyway, that's
Yeah.
Leila clarified that she meant research.
Yeah.
One of the things I think it's really important is to really push for better imaging and diagnostics, because we don't get anywhere unless we can see it. It's just impossible. So the ctDNA, the mutational, what is it? The residual mutational, I can't remember the word of it.
MRD?
Yes, MRD versus, mutations and all those sort of actionable things. Those are very, very important. And actually one of the things that I've just started to do recently is trying to identify trials, especially imaging and trials that are appropriate for ILC or look promising, such as FAP, and try to steer people towards them, to alert people to them, so that we ourselves as a community can enrich other people's trials for ILC. And I was able to get 5 people on a 30-person trial recently for FAP, myself included. So, and there's probably still some more spots on that one. So anybody that's interested, and it's actually, that one is actually for all stages. So I think finding those and like actually collect, getting together and trying to figure out where we want to have enriched populations would be incredibly helpful.
And
we can
Jade, I would
do
just
it for
add,
the researchers.
On the trial front, yes, there's the Plum trial, which is more for the liquid biopsy or the ctDNA in San Francisco, but also other places. So folks out there, please make sure we're getting lobular in there. Although I know they have a strong lobular team. It is specific to lobular, I believe, the Plum trial. So it's looking at ctDNA monitoring there. And to the question people are asking, I'm also bone mets, but have neither FDG or FES lit up. It looks like my bone mets went ER negative. So I'm monitoring via ctDNA with Signatera every 3 months, 4 months, I guess. And it's just hopefully an early warning system, if possible. That's definitely something that I think as an advocate I want to see more standardized, because we don't have enough monitoring tools, and it's not perfect yet, but they're getting better. So driving some of that to be more standard is back to my change is slow. I feel like the whole ctDNA liquid biopsy thing is in that sort of, as someone put in the Q&A as well, right? The doctors, the oncologists don't know what to do if they get an early warning, but they don't have a place to look at a scan, but maybe it triggers an MRI, right? So, and maybe it takes, 3 or 4 tests to get a trend that actually is telling you something is happening, but your body can spike and whatever. I mean, That's
If I
not
can comment too, but
a clear
advocating for
answer.
research. So I'll say that even though my lab has been studying ILC, like I've been studying ILC myself for the better part of 15 plus years at this point. I would have never thought I would study metastatic ILC until maybe 2 years ago. We started playing with a new tumor model, and Donna made an offhanded comment about the radiology on her bone mets and the radiologist not knowing what to do with it because it was mixed lytic blastic. And she happened to make that comment in earshot of my lab manager, who had been before he joined my lab. He studied bone metastasis from bladder and prostate cancer for years, and that like set off an alarm bell for him. And then we heard a similar comment at the ILC symposium that triggered us to start looking at how do we model bone mets using this new tumor model that we're playing with lobular. And like I said, lo and behold, we can actually see that the mouse model does mimic this mixed lytic blastic phenotype. And I wouldn't have done any of it, if I didn't have Donna around and to tell me about what matters for lobular. So for those of you local in Denver, join Front Range ILC. For those of you that are near other universities, get into research advocacy, because I don't necessarily know what to study until I hear about what matters clinically. So I do think genuinely that's a really important way to advocate for more metastatic breast cancer research, especially in lobular. So thanks, Donna. Joe has a lot more work now to do.
Yeah. Yeah. All right. Should we move on to some of the other questions?
Yeah, there was one about ctDNA that I thought, since Carolyn, you mentioned it, that I would bring up about acting on Signatera. I forget where I just saw the question.
Oh, the one that just came up
Yeah,
from
you just
Amy?
had it. Amy asked in the Q&A about
Yeah,
Signatera.
I mean, I don't know that you can act on it on one test, but I think it's still great to have the baseline, right? And
So
to have the trend,
yeah,
if you're
the
metastatic
Serena
in
6
particular.
Yeah, the Serena 6 trial was what was the first trial to see what acting means. So it sounds obvious that, okay, if I have a new signal on ctDNA, especially for A mutations, that means the tumor's back, right? The question, I mean, at that point, because most of these tumors are ER positive, you're probably on an endocrine therapy and getting some benefit from it, question mark. The question that Serena 6 tried to ask is, if you switch before we can see a tumor, does it actually limit the benefit from your next lines of therapy? Are you just, moving the timeline up in progression if you switch early? Serena 6 said no, probably not, in that not only was there more benefit from the first drug switching, but then there was more benefit from the second drug that you had to switch to then after the first progression. So it did argue that switching early was actionable. That was specifically for A mutations and specifically for one oral SERD and didn't have any ILC data. So I think we're getting there where we will have answers on whether there is something worthwhile. I think Carolyn's point about, hopefully your oncologist triggers an MRI, triggers a PET scan, and that is what leads to action.
Yeah.
But right now, a positive Signatera or any of them is technically not actionable, but
And
they're doing the trials to get there.
I'll just add to that, if you have that conversation with your oncologist and they are reluctant to order it, like, you can still ask for it and insist on it, right? Like, it's your treatment. Like, I think a lot of times people think like, well, I have to do exactly what my oncologist is saying, right? Like, if the oncologist recommends a particular treatment and you don't want to do it, you don't have to do it. If you want the Signatera or some other liquid biopsy, advocate for yourself and you can point out, right? I know this, that you're not going to see this as actionable, but I'm very interested in this. I'm interested in the data. I really, I want you to help me get this. So.
I will also say that an
if they
argument
raise
is that
cost, were you going to say cost?
no, I was going to say
one
it's
argument
important
is
to get a
cost, but-
baseline. It's important to get a baseline and to see trends, because if it is consistently going up, that's a signal. So if you don't have that baseline, if you don't get that, you're not going to know what the first one you do eventually is. You're not going to know whether or not it's gone up or down. So you really do need to get serial done. Sorry, Carolyn.
Yeah, no, I think one of the objections I've heard from doctors as well is that, oh, it costs a lot. And yes, they will bill insurance and like several $1,000s, but if the insurance rejects it, which mine did, you can apply and, they have programs that either waive the cost or reduce it. So just don't be afraid of that. You can go to their website.
I'll also say there's also Boston Gene does tumor profiling. Anybody can get their original, if they had original primary tumor surgery done, they should have kept your tissue. And you can actually have that sent out now and find out if there are actionable mutations or things that may cause problems later. For example, for me, I found out that, standard treatment first line was going to be great for me because I had bone only, ER positive, blah, blah, blah. But I do have an ERBB3 mutation that confers resistance to some other treatments that they may have put me on. And knowing that I have that mutation, I would have to do a second sort of form to balance it all out and make sure that I could overcome that, instead of going on a medication that would not work for me and lead to progression while we were waiting to see if it worked. So I think that having that information is also really important. Boston Gene. I mean, I think there are probably other ones, but I do like Boston Gene. And for what it's worth, Jason Wabi really likes them. He said they were very loyal to him and they've been very communicative with him. So I feel like they're open to hearing about lobular, and yes, Boston Gene is a different company.
Foundation medicine is more standard. More centers will use Foundation, Caris. Some of the ctDNA tests do have tumor agnostic panels that just look for mutations. So there's a lot of options. Jason does a lot of research with Boston Gene, which is part of that partnership. Yeah. It's kind of a separate thing. Tempus is another option, Layla. All of these companies have these tumor profiling options. Okay, back in the Q&A, there are a couple ones. Kirsten, you had one about different types of ILC having different physical properties.
Yeah, the reason why I say this is because, I get all the time, oh, it's single line, it doesn't make lumps and all this, but actually I know quite a few people have that lumps, including myself. Mm-hmm. So what I want to know is, are we just excluded from the group? And, and also mine's FDG avid, like nothing else on this earth. Mm-hmm. And I light up like a Christmas tree. FDG is blooming perfect for me. Mm-hmm. So, I'm just like, it's very difficult because I'm hearing a lot all the time, and I say to people, please stop stating things as if they're facts when cancer doesn't have rules. So I just wondered, can you enlighten me about these different types?
Yeah. So I don't know if you caught it. I showed a slide earlier that mentioned solid and alveolar and tubulolobular and these other.
Written it all down.
Yeah, those are the different histological presentations of lobular, and solid absolutely does form lumps. They're different, and I admit that we have, as a field, we've oversimplified this question, I think, in an effort to get lobular acknowledged in the first place. And now that we've gotten to that point, the pathologists in particular are driving a lot of effort to go back and answer those questions that you have. As far as how it presents in feeling a lump and things like that, I don't know anything about that, and that would be a conversation for the community. But as far as then the FDG versus FES, there was a really cool head-to-head study out of one of the European groups that cast a lot less, I guess, doom and gloom about FDG for lobular than some of the smaller head-to-head studies that have gone on in the US. And there was some hint there that whether a lesion is FDG versus FES avid may provide other insight into tumor biology. So I don't think we want to cast you out at all. And I think now that as a field, we've kind of gotten acknowledgement that ILC is a thing, there'll be a lot more attention to go back and understand the variance is the wrong word, but the different presentations of ILC and how to.
Yeah, because I mean, mine still travels in single cells, even though it makes lumps, and other people's will as well. I mean, it'll be the same, that whole thing. And I just think it's, we would need to also show that a bit, because I've had a few people come to me and say, I've got lobular breast cancer, but apparently it's not proper lobular breast cancer because it forms lumps. And I said, well, no.
Yeah, I have the same thing, Kirsten. Yeah, it was a lump.
Yeah, I've known a few people with lumps, so
so we need to figure out messaging better. I think we're at the point where we can do that now, no doubt.
And I would think they all have different characters as well. Cancers, I know that the solid one is meant to be a little bit more aggressive in some ways, and I've started looking into the subtypes, but I haven't looked into any of the subtypes of pleomorphic. I didn't even know pleomorphic had 4 or 5 different subtypes until tonight.
Can I ask
Yeah,
a
there's a
follow-up
really
question about the histological types?
sure.
Because I know that in my case, it just said ILC on my path report. And I'm wondering if it's worthwhile doing retrospective, looking back, figuring out which they were, and looking at outcomes for people that have already sort of like either had 5 years or 10 years or, have passed away from metastatic disease. I feel like looking at retrospectively at that might be able to. I've asked a couple of times, like, well, do you know which type I am? Can I see the slide? And they're like, oh, because pathology is kind of like it's like they don't ever see a patient kind of behind a screen. They're like the Wizard of Oz. So, I'm wondering if anybody is doing that.
The short answer is yes. So Ann
Good.
Vincent Solomon and Christine Desmet are doing more right now, in particular with the
Oh,
histological
wonderful.
subtypes. The group at Pitt is also going back. I mean, I alluded to the fact that we're arguing as a field over what ILC is exactly and how to call it, and this is exactly the reason. Um, it we're arguing enough over how to call single file classic ILC that it's been a struggle to figure out how to call solid alveolar trabecular. So we're not naive to it. And there are groups going back to do the retrospective analyses. And yeah, that's the best I could say for now. On an individual patient level, I would say that there is absolutely nothing your oncologist can do with ILC subtype information at this point. I hope we get there, but it's not going
Right,
to help.
but for the future purposes, if we have our tumor, on file somewhere for like the next 4 years, should we go have it subtyped or
No, because
make sure they
any
keep the
study that's going to
picture?
do it, no, any study that's going to do it would do central review because we argue so much about what any of these subtypes are that they would have one dedicated group of pathologists read an entire cohort of studies.
However,
So,
it does give you measurable disease. So people
hmm.
who have lumps
I
definitely
think
suddenly
7.
have measurable disease despite having
Oh, sure.
lobular breast cancer. And I think this is one of the reasons we need to uh, explore, explore this. I'm so glad they're doing it. I'm so happy you told me
I
that.
agree, but I think right now it's the idea that solid would be measurable for certain trials is anecdote. We just don't have the data to say like we should do X with solid ILC or not. We're just not there yet. But we're not like there are groups looking at it. So hopefully I'm wrong like next year. Yeah, Jake?
I have a question that stems out of the meeting with Dr. Moabi, the breakfast. He said something very interesting, which was that when ILC grows, the reason that FAP, which is fibroblast activated protein, which is the protein that's associated with cancer associated fibroblasts, and those are the stroma building um, fibroblasts that are really only seen really very, very mostly on cancers and nowhere else in the body, which makes them an excellent target because you're not picking them up except for like in the salivary glands and just a little place here and there. They're really only, that's the only thing you see when you do those tests. But he was explaining that he says that ILC, the body responds to it immunogenically by creating scar tissue. And I don't know if he was saying that those cancer associated fibroblasts, that stroma, was a type of scar tissue, which is a very interesting sort of thing to think about. If that is the immune response, so that the cancer cells themselves might actually not, quote unquote, do anything. So they infiltrate tissue, let's say they infiltrate your liver, but like the liver still functions because there's no, it's not until you get that fibrotic, stroma that causes coating. So I was wondering if I'm misunderstanding what he said, or if it was an analogy, or if anybody has any idea if that's any comment.
I have not seen any data to that effect as far as a particular scarring or fibrotic response from lobular. There are like breast cancer in general initiates wound response when it contracts in response to therapy. I know nothing about it being lobular specific.
Okay.
Sorry, I'm not helpful in that space. Lobular clearly does have a different immune microenvironment than other breast cancers. It has a very different complement of macrophages that Carolyn was alluding to. It excludes some populations of T cells. It has a very different interaction with cancer-associated fibroblasts. Just to drive Kirsten more crazy, obviously solid tumors aren't going to have the same amount of fibroblasts that a classic ILC is going to have. So it's different I am the least expert in that space, though I will also acknowledge I am not an immunologist, but I haven't seen data to see, say, a different scarring response yet for lobular.
As a side note, my Boston gene tumor report actually told me that my tumor was enriched for cancer-associated fibroblasts, but I didn't notice that until just recently when I was looking at FAPI. That was something that's been there for a couple of years that just like didn't mean anything to me. And then when I heard about FAPI, I went back and I looked. So that's actually an interesting thing to know that you can like sometimes something will become relevant that's in the report that you never thought would become relevant.
Yeah. That's why I was asking, do we get these snapshots now while that, while that picture is still around, or why the Boston gene can still be done, right? And then maybe it's useful once the trials are done. Yeah.
That's a very good point. It's a very good point. Yeah, some of those, I don't know if there's arguments worth having, but that's an interesting question. I would be really curious if a pathologist would go back and look at subtype right now for that kind of question. Also with the CAF score, just from a research perspective, some of those I'm glad it made sense in your case, but it's worth considering that those kind of scores are just measuring that from what's called deconvolution of gene expression from a chunk of tumor. It's not actually going back and scoring different immune cells. That's a very different question. So some of those readouts are a grain of salt, if that makes sense. They're trying to take an average. They're basically taking a chunk of tumor and reading out an average gene expression, and they're trying to say, oh, well, we know that gene X isn't expressed in epithelial breast cancer cells, but it is expressed in fibroblasts. Therefore, if that gene is high in your tumor, it must be because there's fibroblasts, is a simplified way to explain what they're doing. So they're not bad, but they evolve a lot over time and they mean different things, and they're not the same assay as a pathologist going in and scoring how many lymphocytes are in a tumor. They're different beasts.
Yeah. Can I just say one thing? A couple people have asked me for specific resources that I've mentioned, and I told them in the chat, and I'll tell everybody here to send like what you're looking for to Donna or Matt, because I would want to vet what I send you. Like I have my own research but I'm not a trained doctor. And so some things like trials, I'm happy to just share because of course they're trials and they will screen you. But when it comes to like research into this or that, I don't know. I would just want to sort of filter it through that, and maybe we can collect it all into one thing instead of multiple different messages.
Great. And I just put an email in the chat. This is our FRILC email, so it goes to multiple of us, and we'll do the best that we can to get you answers.
We have a few more minutes. I was going to come back to the chat questions. There was one from Ciara on how do we feel about the future of AI, artificial intelligence AI, affecting lobular. I think AI only is as good as the data that feeds it, right? So as we hear more and more, we can advocate for more and more lobular, which in some cases is excluded from trials because it's hard to measure. So we've got to make sure that these measurements are more appropriate for cancers that don't follow the typical RECIST criteria based on tumor size. Anyway, more data will help AI.
I'm enthusiastic about the opportunities for diagnosis and kind of helping us normalize diagnoses and helping us figure out limiting inter-observer variability and saying, is this one solid? Is this one classic? Are these all lobular? Is there a defining characteristic of all of them that makes the diagnosis more consistent? I think we're going to be able to use it more in our research studies as well. I've been hedging my bets right now on dumping data into AI yet, but I do work with a lot of colleagues that use more machine learning techniques that are more defined pathways for taking big data and defining that into askable questions. And we're starting to explore that with our own lobular data to take, say, single cell sequencing data from our laboratory models where we're looking at what each individual cell in a tumor is doing and understanding how we can ask the machine to help us translate that data back to a patient's tumor where we don't have single cell data, but we can do that, what I just mentioned about deconvoluting. Can we help understand how this tumor sample maybe mimics what we're doing in the lab to kind of link that biology. So there is space for AI and machine learning absolutely in that space.
Yeah, and I think also in that whole pathology space of looking at the, I don't know if that's the right, I think it's pathology, right? Where you're looking at the slide and you're trying to say, is this which kind of lobular? I mean, that's perfect for AI, and that's back to like, are the machines even capturing the right data? And the current interpretation, the Swedish guys showed that the current, variance in detecting is really wide, which I think some of our data shows as well, based on counting in Colorado, right? Next, anything else we can try to hit here in the last 5 minutes, or are we?
Feel free to chime back in if we missed them.
Kira was asking you about theranostics. She's put that down a couple of times.
Sorry, did I?
Yeah, there was the theranostics with FAPI, right?
Kira?
There's a bunch of different theranostic agents that are in the pipeline.
Well, not with FAPI, just in general, liquid radiation. So there's an institute here in Grand Rapids that's studying using liquid radiation to treat small tumors found on PET scans. So they're using it in prostate cancer, endometriosis, very successful. It's a new institute, only 3 years old, but it's very successful. So they're starting to move into breast cancer. And I think out in California, they're studying the same thing. So I just wonder what, the future of using that technology is going to be in effect. I'm not sure with lobular, but they're looking into all breast cancer.
I guess I'm not familiar with it. Is it actually like an injectable of like a brachytherapy type thing?
So it's small amounts of liquid radiation. It was used in children's cancers. So they were finding here, we have in Grand Rapids, Helen DeVos Children's. So they were using it to save and preserve the tissue around the tumors. And so they found by putting in this liquid radiation that only treats the smallest of tumors, it killed that, but left everything else healthy. So they're starting to move in. It was primarily for children, and then they moved into prostate and then endometriosis, and they're just starting into opening trials for breast cancer. And it's called BAMF, BAMF.
Is this BAMM?
BAMF, as in fish.
F. Okay. And is this a theranostic thing? Is this associated with PET scans?
They have the ability. Well, they have. So I was talking to Jason about this at the breakfast. So they have the equipment that brings the testing from 40 minutes down to 5 minutes. So I think the machine they have is the only one in the country. Don't quote me on that, but that's when I took a tour of the place. And Dan Rogers, he's the chief clinical researcher there. He was very hopeful to bring this into the breast cancer arena, obviously with measurable. So the way their testing works, you can get scanned, tested, and treated all in the one facility. And it is it's subsidized by a philanthropist here in Grand Rapids called Doug DeVos. So thankfully, it's not going to be affected by federal funding. They are only 3 years old, but they're opening, what I just read last week, they're opening a new facility in Detroit. So it is growing exponentially, and hopefully in breast cancer, it can be something where it can go in and treat just the tumor area. So I think radiation might become a thing of the past where it damages all other areas. This is liquid radiation. So it literally, theranostics goes right to just the tumor site.
Yeah.
So it's very exciting.
I can tell you that, I can tell you that the industry is very, very, very excited about theranostics. They're putting a lot of money into it, and with good reason.
In California, they've started their own study on it out there. So as far as this being on the East Coast, I think in the West Coast, they're already kind of onto this. I don't know if in the same realm. I don't know the differences of what they're studying on it, but they say it's the way of the future of treating cancer. to be able to leave as much good tissue and the least amount of damage, but kill exactly the area they're going after. So it's very exciting. I mean, check into it. They did have an open trial 3 months ago. It was pretty narrowed, which lobular didn't really qualify because it didn't have measurable site. Most of their studies are at stage 4. So as far as prostate, stage 4, it's not the end game, but it's where people have gone to do this alternative. But it's moving into where this will be adopted all over.
That's great. Thank you for sharing that.
You're welcome.
I think we're closing out here on time. Matt, you want to wrap us?
Thanks all for joining. I think at one point we had at least 60 folks online, so that was absolutely outstanding. I hope this was a good resource and informative for everybody. Thanks so much for the vigorous discussion. There are email addresses in the chat that went out for Front Range ILC, for LBCA, and you all have my contact information. So please reach out with more questions, and I hope we can continue to be a resource for this community moving forward. So,
thank you for all that you've done. That's great. Put it together.
You're all a great motivation, I'll tell you that much.
Thank you so much.
Have a great night, everybody.